Okay, we're ready to go. Now, I was really interested this morning. I'm Donald Macaulay. I'm one of the editors at the BMJ. But before I joined the BMJ, I was the editor of the British Journal of Sports Medicine. So one of my big interests is in sport. So when Helen stood up and said, much to my surprise, said, what are the principles of sport that you could bring into healthcare? I really sat up because that's something that really interests me. How can you bring those really positive management principles of sport where everybody, when they line up, assumes they're going to do their best, where all the individuals are working for the team, and where everyone is focused on the same goal? How can you bring that into healthcare? And that's a real challenge. So when I saw the people that are going to speak at this session, I thought, well, now this is where we're really getting going. Because what we're going to talk about in this session is applying management principles in healthcare. So our first two speakers, James and John, have very interesting backgrounds because they both have dual interests in sort of management and healthcare. One started off in LSE, in the sort of management centre of excellence, and moved into healthcare. And the other is in healthcare, went on a Harkness Fellowship, worked with McKinsey. I was asking him, how does that work, integrating healthcare and management? So I hope you're as interested and enthusiastic as I am. We have a double act from James and John. Okay, guys, ready to go.
Thank you, Donald. So I'm James Mountford from UCL Partners, and as Donald said, this is a double act between two colleagues from two systems, one south of the river, John's system at King's Health Partners, and ours north of the river, and our partnership extends to the territory that you're in. So as a Londoner, those of you who are out of town, I hope you've had a great time in London. It's a lot of competition for these different sessions when you look at the programme, so thank you for choosing to come to this one. And if you'll pardon the pun, time is precious, value is about how we use precious commodities, and I hope this is good value for your time. So here's our proposition, really. We're going to offer you a definition of this concept of value, the relationship between the outcomes that we get for patients and the resources we use. We're going to try and leave you, maybe above all, with a way of engaging your colleagues in a narrative, a story around value. And I want to just ask for a quick couple of shows of hands. Who would primarily say, let's just see who's in the room, who would primarily say that you are a clinician? So your main job is clinically focused with patients. Okay. So that's about a third of you. How many of you are primarily in a management role? Okay, so, and how many of you are in a kind of a different role, in a policy role perhaps, or something? Okay. And how many of you are sort of primarily improvers? Okay, so fine. So, final question. How many of you think that all of you at some level have the same job? Okay. So that's what this is about, really. It's about trying to find a way to put us all on the same page around value for patients. And we want to have some practical tools for you. So our proposition then is that healthcare is very complicated, that this concept can unite and put us all on the same page in a practical way. There are some things that we can easily build on, but there are some parts to implementing value that are really quite tough. But that shouldn't stop us from the Monday morning test. You could all go back to your workplaces, we think, and start working on this if you're not already on Monday morning. So this is a slide from the New England Journal last year when it celebrated its 200th anniversary. And to me this speaks to a very nice problem to have. So these are the advances over my father's lifetime in cardiovascular care. You'll see advances here in terms of medical technologies, drugs and devices. You'll even see, if you look here, 1961, an advance in an organizational sense. So the creation of a coronary care unit. an organisational intervention for patient benefit. And you see the mortality falling. What is the consequence of this? Well, one consequence is that we are spending more and more money on healthcare. That is a good thing in many ways. But if you look at these lines from across countries, and maybe one final show of hands, if you come from a country where you don't think that the money is getting tighter and that there's ever more need to justify the spending or to use the spending better, please put up your hand, and I'd love to find out who you are and come and find out what you're doing at the end. So these curves from all sorts of different countries with very different types of health system in terms of public versus private, the way it's financed, these curves cannot continue to diverge forever. If they do, we will be spending all the money we've got on healthcare. And in the middle of this is a patient. This is our favourite patient at UCLP. She's not a real patient, but she's a very typical patient. And I'm not going to read all of the stuff there, but I think those of you who are close to care, or even just think about maybe your own care as a patient or that of a parent or another loved one. In most systems, Edna is very real. Edna has COPD, she has some other diseases as well. She falls through the cracks in the system. Information isn't passed on. She sees one person who recommends something, another who recommends another. And in the middle of this, Edna is bouncing in and out of hospital, which does harm to her. As a minimum, it's inconvenient, but it may expose her to harm, and it spends the money of the system to zero useful benefit to Edna versus keeping her well and at home in charge of her own care. And we'll come back to COPD with some local work in London in a moment. So this is a graph, for those of you who can read the axes, we've got mortality as a proxy for quality on the bottom and cost on the vertical axis. Now, I'm not a statistician, maybe there are some in the audience, but I know that there is not a very good correlation here, okay? So each dot is a hospital, and you can have some very expensive hospitals that are giving very high mortality, and vice versa, the sweet spot, the cheap hospitals with low mortality. Now, again, any system that I've seen, this sort of variation exists, and the relationship between the resources and quality is complicated. So let's come to this paradigm of value, and John will take over in a moment and talk more about some of the context and the barriers that this sits. But I think what we're arguing here is that things come in cycles, and we've been through the cycles of thinking that care is completely disorganized and can't be controlled, to an era of process control and efficiency, the birth of the safety movement, and now we've been focusing on an era of quality improvement, and now we're realizing that improvers have to focus on the use of resources as well. Donal mentioned that I was a Harkness Fellow. I did that at the IHI in 2005 to 6, and this was a very new concept for improvement then. It led to the triple aim. But this idea that we're all responsible at some level for the quality and the money is quite, I think, a deep concept. And that leads us to this value equation here at the bottom, that value is the outcomes we get, the useful product in terms of things that are relevant to patients and populations over the resources that we consume, and measuring that over full cycles of care, not just episode by episode. So at that point, over to John.
Next slide, thanks very much. So, outcomes. I have the value equation above my desk at work. My wife thinks I'm pretty sad because I also have it in my study at home. And I walk around with it, and I use every possible opportunity to talk about it, as I'm sure many of you do. And at the heart of the value equations are the outcomes, because that's the purpose of healthcare, to try to deliver outcomes that matter to patients and to deliver them over the full cycle of care. It's actually not what most of you do. Most of you are in some chunk of the healthcare system, and you get out of bed in the morning trying to do something helpful in that chunk, but you're not thinking about the whole cycle of care, or at least many of you aren't. Because the healthcare system and the individual components of it are extremely badly designed. I'm a pretty old guy, but even I wasn't responsible for what happened in 1948. And we put in place in the UK a system that is not joined up. And that system is just not designed to achieve the outcomes that matter to patients. It's not designed to achieve those outcomes over the full cycle of care, and we need a major change in the mindset and the organization if we're going to improve things. We are, in effect, currently stuck. Now, I'm a pretty optimistic bloke, but I do get gloomy because I'm a clinician. I was medical director for a long time of my hospital, and I'm currently sitting on the clinical commissioning groups that are now running the healthcare system for 2 local boroughs. I sit on the health and well-being committees of the local boroughs, and everywhere I sit, I see it's not joined up, and nobody really understands this, and nobody knows what to do about it. So we are stuck. We do not, when I say we, I mean everybody in this room, we do not have clarity and consensus of what we're trying to do. We're not organized as functional, integrated teams, networks, working across cycles and pathways of care. We do not, and this is of course hugely important, have adequate data on outcomes, and we have very little on costs, and we don't have them on the same page like the illustration that James showed you. We don't have an overarching value-based healthcare framework with which to performance manage our system. And we absolutely do not have payment arrangements and incentivization that is designed to drive value. So the bottom line is that improving value, outcomes that matter to patients over the cost of producing those outcomes over the full cycle of care, is not central to the professional identity or education of all of us. So we have a long way to go. What we spend most of our time, and I'm sure most of the people in this room, they've probably escaped from conversations to come to this conference at which they were discussing costs. Everybody talks about costs, particularly when the money's tight, but obviously costs are only a part of the value equation. It's actually very difficult to reduce costs, and you all know that to your own cost. And when you do cut costs, you often reduce value. Furthermore, you spend all this time cutting costs which distracts you from innovation and driving improvement and creating value. And Helen will talk about this later, but often if you can improve outcomes, you reduce costs. And she will talk about that a lot more. And certainly you need to understand the value proposition when you are cost cutting. You need to know what the impact that will be on outcomes as well as on costs if you're going to cost cut in a way that minimizes the damage to value. As James has emphasized and as I've emphasized, what we're interested in is measurement of quality across whole pathways. This is the example of stroke, but we could take a lot of other conditions. Nobody in this room wants to have a stroke at all. If you are unfortunate enough to have a stroke, you want to recover well and not have disability. If you do have a stroke, you sure as hell do not want another one. So you have to think about what's happening along the whole pathway of care. And at the moment, of course, all the attention, say in my hospital, is focusing on the middle of this, what's going on in the hospital. So when I speak to our guys and I say, what about your outcomes? They say, oh, the mortality in the hospital's great, by which they mean it's low. But they don't know much about what's upstream and what's downstream. Even the tremendous work done by NHS London to improve stroke services focused almost exclusively on number 3, the middle of this, and not the upstream and the downstream, which is what you've got to do if you're really going to drive value. You've got to start somewhere, though, and it's reasonable to start thinking about value in your bit of the equation as you get going on the value proposition journey. And at King's Health Partners, we have 2 hospitals that provide cardiac services, and we're trying to figure out what to do with those services. One is at King's College Hospital and one is at St Thomas's Hospital. And what would be the way that we could maximize value? So we did an exercise looking more closely at those 2 services. So we looked at outcomes. This particular slide shows the data for coronary artery bypass grafting and for aortic valve surgery. And those outcomes can be got in some detail. And the more we looked at these outcomes, we found that the outcomes were pretty similar. So actually, there was no great difference between the 2, and the same was true for aortic valve surgery. And actually, even when we looked at cardiology, based on the available data, both the services were pretty good. But actually, we want to be the best in the world, so pretty good isn't good enough. But what about the value equation? So we pursued it a bit further. This just gives you the activity of those 2 services. I've called them KHPA and KHPB to sort of protect the guilty and the innocent, or whatever the right. Because when you do produce data like this, it itself initially produces antibodies, whereas of course what you want to do is to produce collaboration and discussion. So they're moderately big services and they're fairly similar and they do a range of activities. At the bottom you see the income. This is tariff, this is not cost. This is not cost. So how do you get at cost? Maybe Helen will help us a lot with that, but it's very, very difficult. But one thing you can do is look at the resources used. And I think this is quite a good approach. Look at the resources used. And when we did that and looked at the resources used, you'll see that one of the services uses to get the same outcomes, less staff, less consultants within that staff number, less beds, less catheter labs and operating theatres. So it seems reasonable to say that these data suggest that one of them looks to be better value than the other. And of course, when you come up with these data, it's not to go around hitting people with a stick. It's to get people in a room and have a discussion and say, well, what can A learn from B? And that means digging further into the data. And when you dig further into the data, what you find is that compared with A, B has higher day case rates. It has shorter lengths of stay. It has higher percentage utilization of resources. And therefore, the 2 working together, A does indeed learn from B, but working together, of course, they will produce an even better outcome, which is what we want if we're going to be world class, which is C, a position of greatly increased value. So we are developing these value scorecards, and this is a value scorecard on myocardial infarction, taken from Boston, from the Harvard group of hospitals. And we are unashamedly stealing their approach. And that's what this shows. And I won't go into detail because I'm anxious to finish soon and hand over to James. So the thing about outcomes, though, is that when you've got them, you've got to make them transparent. I won't talk through this in detail, but if you don't make them transparent, you will not drive the change that you want. If you do, you will. James and I, in different academic health sciences centres and with our colleagues at Imperial, we have regular meetings. And it's so important when you're driving value forward to meet, to discuss, to figure out, to improve, and to learn from each other. And this is just the agenda from our last meeting, where we covered frailty and the patient experience, and indeed costs in our pursuit of value. Long-term conditions are a huge opportunity for value-based healthcare, because everything I've said about looking at the whole cycle of care applies. COPD is an extremely good example, and you can see some of the information on that slide. So the goal is the co-creation of integrated care pathways involving commissioners, patients and carers to drive value. These are the data for COPD derived from the wonderful London respiratory team, in which they have produced a hierarchy of what are the most valuable interventions. And I don't have time to go into it, but some interventions that we do are of low value, and many things we don't do with vigor are of very high value. Okay.
So that's the point, is how do we, let's think back to Edna, how do we use cheap, simple interventions reliably around an education and an improvement method, feeding data to people about things they care about to improve steps of care to benefit Edna. And I'll just very briefly say that in the place where you're sitting now is one of 4 London boroughs where we did some work across all of the primary care practices, nearly 200 of them over the course of a year, where we said these are some quality measures for COPD as enshrined with the NICE guidelines built on by the local GPs. Applying this method, those things got better. Particularly proud that the self-management plan rate or number in the population of COPD patients tripled. And that's important, because the biggest predictor of going into hospital with COPD is if you're lonely, if you're anxious, if you don't think that you can control your disease. Here's the tool that we use to help patients understand. Are they getting the care? Are they accessing it in the right way? Can they have the right conversation with their physician? Here's some of the data on patient experience. We looked at confidence. We looked at whether people felt well informed. And that leads us to this, which, we think we want to double down on in other long-term condition work. What we see is quality moving up and cost moving down. And that, we think, is the sweet spot for value. No inherent benefit to Edna bouncing in and out of hospital. No benefit to the hospital. In fact, quite the opposite. Our A&Es, EDs are overcome with an epidemic of frail patients who fall through the cracks, as national voices say up here. So we don't have time to talk about our frailty work, but let me just say this is the next horizon for us, and I think this is shared by many health systems. Frail elderly people, too much variation in their care. We're not organised around it. We're organised by cardiology, by respiratory, people who look after other bits of the body, mind and body separate. So we're trying across London, the groups that John referred to come up with a set of measures. What does good look like in terms of quality, relevant to patients? And what are some proxies for cost? You can see we're just starting. We don't even have the scorecard yet. But what we're doing is creating a conversation that unites clinical professionals of different breeds, different tribes, different specialties, in and out of hospital, with people who've been in previous times more concerned about management and operations, what we call in the NHS performance. And performance in the NHS hasn't traditionally included quality. And then we think that's odd. So, as John said earlier, we think that value can unite everyone, the patient, the population who are funding the care, and professionals around a common purpose. I'll just give the final word to Roy Lilly, who's a commentator in the NHS, who says this: if you were a member of my own family, I'd do it like this. If I was spending my own money, I'd spend it like this, and if we swap places, this is how I'd want to be treated. And I think in those 3 sentences is a lot of wisdom and a guide for us when we get back to our workplaces. So we'll stop there. Thank you very much.
Thank you very much indeed, James, and indeed, John. That was super. I love the idea of thinking about this patient, about Edna, about this imaginary patient, because it really focuses the way you think about the care you're delivering. Now, have we any questions for James and John here? Because we have a bit of feed here. Howard, what's happening on Twitter there? Do you want to just give us a little bit of feedback on what's happening?
Yeah, so we've had quite a few comments saying that it is really the focus on outcomes which is vital if we are to focus on patients, and it's also clear that people feel that transparency in outcomes is absolutely vital.
Great. Now, that's a photograph. It's not a question. Any questions, folks? There's a question at the very back. Howard, can I ask you to take the question at the very back? I think you're going to meet in the middle, and we have a question here, and I'll pass you the microphone.
I have a question. When you presented comparatively the 2 units, I'm Marius Paravano from Wigan, England. I'm a surgeon. So you presented the Unit A and Unit B, but in your slides you focused actually not, I haven't seen any clinical outcomes, I've seen just value and cost. And you did say that cost is difficult to cut and you have to focus on outcomes because improving outcomes reduces cost. Am I to assume that the clinical outcomes were the same for the 2 units?
Yes, I hope the first slide showed that. So using all the data available, a lot of it nationally, from surgical registers, and you're aware of all that, the two units are pretty well indistinguishable. But I would point out that they're outcomes that are focused on things like mortality. They're not necessarily all those outcomes that matter to patients, and they're not outcomes around morbidity downstream. So they are limited, but the outcomes that we did get were the same for the 2 units, but the use of resources and therefore the costs were different.
Thank you very much, John. Howard, do you have a question there?
Yeah, I was... Congratulations, first of all, for great presentation and great work. You didn't have time to go into the cheap and workable solutions for integrated care. Would you be able to quickly list them for me at all, in terms of what were the solutions that you found that worked for integrated care pathway?
So, I don't know which health system you're from.
I'm from UK. Currently.
From the UK, okay.
Yeah.
So my sense is that we in the UK have been talking about doing integration for a very long time. And we have identified the things that are features of well-integrated systems, and they're very well described, and they're to do with things like clinical leadership, to do with data, to do with governance, to do with payment. We haven't made a lot of progress. You can find examples of things written up 5 or even 10 years ago, and yet it doesn't feel to me like we've overcome those barriers through the system. So I think the approach that we're trying to take, and we make mistakes and we double back and we try and learn, is actually to just go to the front line and go to the patients and say, how does it feel for you? How could it be for you? And kind of stop taking this from a policy angle and come at it from a frontline work or customer back angle.
Thank you. I just was wondering if it would be okay for me to email you for some specific solutions that you've identified that add value.
And your email address is?
So it's up there.
I can see.
So let me just 2 things I would say is I would say put the patient in the room, literally listen to the patient, find an Edna, and then find some data that is practical and that people can mobilize around. You will never get the perfect data. That in itself is a journey, but start somewhere that's more helpful in terms of feeling that the data is empowering towards you improving on things that you care about, rather than just jumping over a hoop that someone else has told you should care about.
And I would add that in the room when you're having the discussion with the patients, make sure the commissioners are there. Because if you don't make deep friends with your commissioners, life's just impossible.
Thank you.
Thank you very much, James and John. That was super, really wonderful.